Our next speaker is also near and dear to my heart. He's a new addition to both the pediatric arrhythmia program and the adult congenital heart disease program. Dr. Jeremy Moore joined us recently from Vanderbilt, where he did his electrophysiology training. And in his short term here has already become part of 3 multi-center trials. He's won the teaching award from the fellows already and has published several articles. He's going to be speaking to us about arrhythmia incidence in congenital heart disease.
Thanks, Kevin. So I've been given the topic of the lifetime risk for arrhythmias in congenital heart disease. I have 15 minutes to do this, so I'll do my best here. So there's over 1 million congenital heart disease patients in North America currently, and that stems from the fact that about 1% of all newborns are diagnosed with congenital heart disease, and currently the majority are surviving to adulthood. Currently, estimated numbers are 85%. Due to improved surgical techniques and better postoperative care. These patients are at increase for arrhythmia just regardless of what their underlying anatomy is in comparison with the general population. But the anatomy that the specific anatomy that they have determines their degree of risk. And some estimates currently are about 15% of adults with congenital heart disease have some form of atrial arrhythmia. So this is a huge burden to society and to the healthcare system. So I'm going to talk about some of the more common defects that we see in clinical practice, as well as some of the defects that are really associated with a high burden for arrhythmia. We'll do ASD, Tetralogy of Fallot, transposition of the great arteries, whether it's the repaired by an atrial baffle procedure or an arterial switch, single ventricle, really Fontan patients, and Eisenmenger syndrome. So to start with ASDs, really, the literature sort of shows us that about 20% of patients that reach the age of 40 without repair and ASDs will have an atrial arrhythmia. The breakdown of those arrhythmias is that atrial flutter tends to predominate at younger ages, whereas atrial fibrillation then exceeds that in older age. One of the studies specifically looked at sort of breaking these ages down into specific categories, and they found that patients under the age of 40 tended to have atrial flutter. The middle age, 40 to 60 year range, there was sort of equivalent estimates of atrial flutter and atrial fibrillation. And in the more elderly population over the age of 60, atrial fibrillation predominated. Now, when we look at the pediatric literature and the follow-up data from pediatric repair, defined as repair performed before the age of 18, we do see that there's a significant reduction in future atrial arrhythmias. The sort of follow-up period of about 30 to 35 years in many of these studies has shown that about 5 or 6% of these patients will still develop atrial arrhythmias, but it's significantly less than the unrepaired adults. And unfortunately, with late repair after the age of 40, we don't see as much benefit to ASD closure as we do with the younger patients. And the Gatsulis from 1999, this is older data, but really showed that age of greater than 40 at the time of repair was showed that there was quite a bit of recurrence of atrial arrhythmia and an attrition of several percent in the ensuing years, whereas patients under the age of 40 did not have that same problem. So although there's many other benefits to ASD closure, arrhythmia reduction is not as big as a benefit. As far as sudden cardiac death goes, though, atrial septal defects do not carry a big burden for sudden cardiac death. And if you look back at the Silka study from 1998, this one most people will quote for sudden death, they didn't find any sudden deaths in their group after 7,000, almost 8,000 patient years of follow-up. Next category, Tetralogy of Fallot. Initial focus was on sudden death in this patient population, initially thought to be due to AV block, and later was found to be really related to ventricular arrhythmia. But in the decades that followed, we really realized that atrial arrhythmias was really the biggest burden that these patients faced on a daily basis. Some early studies showed prevalence rates of 12 to 34%, and not only was there a huge burden with respect to symptoms, but also event-free survival is worse with atrial tachyarrhythmias and Tetralogy of Fallot, whether it's congestive heart failure, hospitalization, or mortality. And so this is a graph just showing the difference between those two groups, arrhythmia-free versus atrial tachyarrhythmias. More recently, the Paul Chiari and actually multiple centers, including UCLA, were involved in a study looking at the arrhythmia burden in Tetralogy of Fallot. This was an adult study and really looked very closely at all the different types of arrhythmias that these patients experience. And they found that the most common overall was atrial arrhythmias, again, not surprising from what we'd learned previously. 20% of patients in this study had some form of atrial arrhythmia. And intra-atrial reentrant tachycardia was the most common, followed by then atrial fibrillation and then other subtypes of atrial tachyarrhythmias. Similar to the ASD group, they also found that atrial fibrillation was more common than the reentrant or flutter types of macro reentry after the age of 55. And this group also did a lot of catheter ablation, so we kind of knew we have a breakdown of the different subtypes. Intra-atrial reentrant tachycardia was the most common, but various other types like non-automatic focal atrial tachycardia, AVNRT, ectopic atrial tachycardia, accessory pathways, and so forth were also seen. But a little bit surprising, they found also that there's quite a bit of ventricular arrhythmia in this group, and more than we had probably appreciated previously, 15% as opposed to 20% with atrial arrhythmias. And almost all of these were sustained VT. And it turned out that if you looked at the subtypes of atrial tachyarrhythmias, sustained VT was actually the most common arrhythmia subtype in this population. So again, sort of calling attention again to what we focused on before, that ventricular arrhythmias is very important. Now, it's important to note that the 20% of this population had implanted devices, so the very good detection rate for ventricular arrhythmias. But this was one of the interesting findings from this recent study just in 2010. As far as sudden cardiac death goes, though, there's quite a few studies looking at this over the years. This is sort of a table I just put together that shows the incidence in various studies. A total of 2,000 patients, 44,000 years of patient years of follow-up, and 84 sudden deaths for an overall incidence of about 0.2%. And you'll see anywhere from 0.1 to 0.25 really quoted in the literature, but it seems to be about 0.2 or so percent for Tetralogy of Fallot. And that's similar to what Mike Soka published back in '98. Next group is the detransposition group with atrial baffle operations. The original atrial baffle operation proposed was the Sending operation in 1959. This includes multiple incisions and suture lines in the right atrium and actually the left atrium as well. And there is the risk for sinus node damage and damage to the arterial supply to the sinus node with this operation. There's subsequent revisions and modifications have been proposed, but as you can see, this is the original description. There's multiple incisions and suture lines in the atria near the sinus node. Subsequently, the mustard operation was introduced in 1964, 5 years later, and as opposed to using only native tissue, this operation included synthetic material for rerouting of the blood flow, including a pantaloon-shaped baffle here, which redirected systemic venous flow to the left ventricle. But again, there's multiple suture lines, and this baffle, the suture lines and this baffle both run in close proximity to the sinus node, which would be expected to increase your risk for arrhythmias. And that's basically what we see. If you look at the literature on atrial arrhythmias in the Sending mustard population, we see a very high incidence of arrhythmias. It's important to keep in mind what the population is when you're looking at these studies. Some are mustard patients, others are Sending, some are mixed. And there's different eras of surgery as well as different definitions of what atrial arrhythmia really is. So some include symptomatic tachyarrhythmias requiring treatment, whereas others incidental Holter findings. So it's really important to pay attention to that. But if you look at the overall long-term follow-up data, it looks like about 25% of these patients will have some form of atrial arrhythmia at 20 years. So it's a pretty high burden of arrhythmia in this population. This is the Kaplan-Meier curve for one of those studies, which will follow patients out to 20 years, and you can see a steady decline in arrhythmia-free survival. Then also sinus node dysfunction, again, because of the way these are repaired by necessity, there's going to be some damage to the sinus node. And studies here show even more pessimistic sort of overview of sinus node dysfunction over time, such that about 50 to 60% of patients will not be in sinus rhythm at 20 years. And if you see the survival curve, it looks considerably worse. So next category of arrhythmia in this patient population is sudden death. Most people quote an incidence of about 0.5% per year. If you look across the board at different studies that have examined this issue, you see anywhere from 0.13 to 1.2%, but pretty consistent actually, about 0.5% per year, which is higher, much higher, actually double what we see in Tetralogy of Fallot. So this is a big problem in this patient population. This is the SILCA data reflecting the same thing. Risk factors for sudden death are variable. I wasn't really going to go into that, but atrial tachyarrhythmias does turn out to be a risk factor. And then systemic RV dysfunction and tricuspid regurgitation are the sort of the big ones that have been proposed over the years. So the arterial switch operation came along really as a result of all of this in 1976. And so patients are currently about 35, 36 years out, some of the early ones from this operation. And so what's the data on arterial switch? Well, there's only a handful of studies really on arrhythmias, but of those studies, they show a very low incidence, which is what we all would probably expect. This study from 2002 showed a 3% incidence after 25 years of doing that operation. And most of what we see is similar to other congenital heart patients, such as sinus node dysfunction, SVT, and flutter. Unfortunately, 2 patients in this study had ventricular fibrillation, which is one of the key issues to be aware of when you're talking about arterial switch operation, one of the risks that you might face. And this is their survival curve. Patient with SVT, a patient with sinus node dysfunction requiring a pacemaker, a VF arrest resulting in sudden death, another VF arrest that was aborted and resulted in an ICD implantation, and then a patient with flutter who had 2 prior surgeries. So not a lot of arrhythmia, but the arrhythmias that we see can be pretty devastating. A subsequent study from Japan, 2006, essentially showed almost the same thing, an incidence of around 3%, and similar arrhythmias, sinus node dysfunction, AV block, atrial fibrillation, SVT, and again, they showed a patient with VF in their study as well. So important to pay attention to the coronaries, obviously, when you're talking about arterial switch operation. This is a patient with our institution that had coronary artery damage as a newborn, ended up with an ischemic dilated cardiomyopathy and had an ICD placed, had recurrent shocks, and then underwent an ablation procedure. And this is just a map of the RV and the LV, and there's a scar along the course of the left anterior descending artery that was responsible for the ventricular tachycardia. So sort of re-emphasizing the importance of the coronary perfusion in this population. The Fontan operation was first described in 1971. There were various modifications. There's a classic Fontan, the modified Fontan, the lateral tunnel, the extracardiac conduit, and in some centers are performing extracardiac pericardial tube operations. As far as the subtypes, the classic Fontan, I think somebody showed this earlier actually, the cross your heart Fontan. Modifications to that were all atrial pulmonary connections, at least initially. And reports started emerging with just alarming rates of arrhythmias in this population. So that led to the first major modification, the lateral tunnel procedure in 1988. And that was followed 2 years later by the extracardiac conduit. And then subsequent research, this is a study looking at canine-induced, or canine model of reentry in lateral tunnel Fontan, suggesting that suture line along the crista terminalis is very arrhythmogenic, and so subsequent modifications, we try to avoid that area of the heart, but we still see quite a bit of arrhythmia. And if you look at the overall studies on this, there's pretty consistent and dramatic degrees of arrhythmia over time. The one study that I found that followed this out to 20 years showed an incidence of 50%, and that was a relatively recent study in 2004. Important again when you're looking at studies to sort of remember what patient population you're talking about. So not all of these are either extracardiacs or lateral tunnel Fontan. Some are the old atrial pulmonary connections. As time goes on, we're starting to see less and less of the atrial pulmonary connection, and we might see that this arrhythmia burden goes down, but that's still sort of to be seen. Most of the studies have consistently shown a steady attrition of arrhythmia over time, anywhere from 2 to 6% per year. A recent study from Stevenson in Toronto showed that the risk seems to be highest actually in the first few years and reaches a nadir around 5 years, and then progressively, sort of steadily increases after that. And then lastly, as far as the Fontan goes, people have looked at the different subtypes and tried to determine which ones are at greatest risk for arrhythmia. And really early on, we found that the lateral tunnel was associated with less arrhythmia than the atrial pulmonary connection. And then more recently, Stevenson in 2010 looked at tried to show a difference with the extracardiac conduits relative to lateral tunnels and the other subtypes. And they did show that it was a trend towards less arrhythmia with extracardiac conduit Fontans as well, although it did seem to be that they need a little bit more as far as power goes to show a statistical difference. Finally, I'm going to talk about Eisenmenger syndrome really briefly. First described in 1897, the Eisenmenger complex, and then subsequently some other contributors to Eisenmenger syndrome were Richard Bing and Paul Wood in 1958. These patients are pretty high risk for mortality, have high risk for mortality. Various mechanisms: congestive heart failure, brain abscess, complications of pregnancy has been discussed already, pulmonary hemorrhage, massive hemoptysis, stroke, and arrhythmia. And it is a little hard sometimes, I think, to tease out which of these are arrhythmic risks, or arrhythmic deaths, rather, because a lot of these are sudden. But looking at the data, people have tried to do this, and it does appear that sudden death and presumed arrhythmic death does make up a sizable proportion of these deaths. Anywhere from a third to a half of deaths are attributed to arrhythmia. But again, I think that you need to exercise a little bit of caution when you're talking about sudden death versus arrhythmic death, because there are multiple mechanisms in this population. Also, when we talk about sudden death, came out this month in Circulation. Eisenmenger syndrome really leads the pack as far as contributing to sudden death in the congenital heart population. So 19% in this series, 19% of deaths were Eisenmenger, which equaled that of the atrial baffle patients with congenitally corrupted transposition. And then that was followed by Tetralogy of Fallot. So, in the grand scheme of things, Eisenmenger syndrome is a big one as far as sudden death goes. And this is just a graph showing a sort of median life expectancy of 52 years. And complex lesions are more likely to basically die than simple lesions. So that's all I have at this point, but I think some of the next speakers are going to talk about what we can do about make this better. Okay.